Thank you very much. Again, I would like to thank Antonios and George for the invitation and the very kind hospitality. It's quite a challenge to be moved to be the only thing blocking you from the lecture hall to the coffee break, so I'll try to make it as fast as I can. I do want to add one comment which pertains to the previous talk, Graham, and that has to do with the fact that in Israel, most patients that all over the world would be regarded as requiring critical care, say looking at ventilated patients, most ventilated patients in Israel are not in ICUs. They are on regular floor beds. And I think we are unique in that. I think we're the only country that produced at least 2 studies that have shown that these patients, when they are on regular floor beds, have a significantly poorer outcome than when they are in the ICU. But I was asked to talk about computerized patient records and try to show that this can be a quality improvement tool. It has some reference to some of the things that were mentioned by Dr. Barash with regards to using technology in terms of design and things that will make our care better, maybe even have some impact on cost effectiveness. But we can start by looking at the fact, this is from the Harvard adverse event studies, that almost all clinicians in all fields have adverse events to various degrees. So harmful things and bad things while we are providing medical care are fairly common. And one of the solutions may be to go to electronic records, not just because carrying the paper records is very, very heavy and cumbersome. And in fact, in various aspects, it has been shown that electronic health records can improve outcome. This is not from critical care. This is from ambulatory care regarding diabetes management. But this shows actually that if you look, what they did here is they looked at institutes that had computerized records versus non-compute versus paper records. And you see the numbers above 0 are the ones where the outcomes were better than if it was on paper. You can see that for almost all types of patients, all types of insurances, if the institutes were using computerized records, the outcome parameters for diabetes care were better. And in fact, there was a report to the president, a commission, a President's Council of Advisors, which not too long ago noted that there is an advantage in going to electronic healthcare. And we can see that they said that improved health IT can directly affect and improve clinical encounters between doctors and patients, healthcare organizations, research, and monitoring of public health. But we need to improve and look at the electronic health records somewhat differently. And it is complex. They continue to state that the state of health IT today can be summed up as a mixture of good things, bad things, things that aren't working well. And there is a lot of issues that have to do with billing, issues that had to do with qualities. And it's amazing that most physicians, at least in the United States, still do not use electronic health records, while the potential does seem to be significant. And we're all trying to become paperless. You know, we're trying to get the paperless office, paperless communication, paperless data storage, but it doesn't always, you can't probably go all over the world and be completely paperless in everything. And a main problem with the record, or with problems rather, health, adverse events and harmful things, has to do with communication. And this, of course, pertains to what we'll be talking about with regards to the health record. One of the major roles of the record is to facilitate communication. So look, this is from the JCO database of sentinel events, of catastrophic events that happened that were reported between 1995 and 2005 in the United States, 3,500 events. The most common etiology or main reason for the adverse event had to do with communication. And communication in healthcare is very, very complex, particularly in emergency situations. And I'd like you to have a look at this little video.
Watch out! An angel. Little girl?
Yes, sir.
I want you to do something very important, all right?
Okay.
I want you to run home, and I want you to call the ER of North Bank General Hospital, 932-1000. Tell them to set up OR6 immediately and contact anesthesiologist Isadora Turek, 472-2112, beep 12. Have them send an ambulance with a paramedic crew, light IV, D5 and W, KVO. You got it?
ER North Bank General Hospital, 932-1000, set OR6 contact anesthesiologist Isadora Turek, 472-2112, beep 12. Ambulance with paramedics and light IV, D5 and WKVO.
That's good.
Sounds like a subdural hematoma to me.
Oh, it does it? Well, it's not your job to diagnose.
But I thought...
You thought, just go! 3 years of nursery school and you think you know it all. Well, you're still wet behind the ears. It's not a subdural hematoma, it's epidural. Ha! God damn, that makes me mad.
So, communication can be difficult, and we'll go back to the slides. Okay. And the electronic record may enable us to actually improve that a little bit. And, you know, why do we maintain the record? So I'll go a little bit into anesthesia here. And I'm sure many of you know this man. This is Harvey Cushing, who was a neurosurgeon. But the story is very interesting when Cushing and Codman, who was another famous neurosurgeon, were medical students. They placed a bet. Medical students were then assigned the job of providing anesthesia. Yeah, we all know anesthesia is actually one of the simplest things you can do, so any student can do it. But at that point in time, they were competing amongst themselves about who would provide the better anesthetic. And to prove that and to settle the bet, they created an anesthetic record. And this is one version, I guess, of the first anesthetic, or one of the first anesthetic records that they created. And you can see it's full of things that are written. Actually, here is an anesthetic record from a later time. Cushing was the surgeon here. This is nice because although it's a handwritten record, everything is typed. I don't know when the anesthesiologist had the time with a typewriter to put in the name of the procedure, etc., and write that the patient was very, very agitated during the surgery, actually. So these are what anesthetic records look like, and they are often, when they are handwritten, the record is not really very, very accurate. And this is a study by Dr. Reich, who tried to show, who compared paper record with a computerized record and showed whether there was a difference. And I'm sure nobody in the audience will be surprised to see that if you looked at the systolic blood pressure in the handwritten record, if you look at the peak systolic blood pressure in the handwritten record, was usually lower than it was on the computerized one. On the other hand, if you look at the trough of the systolic blood pressure, it was actually somewhat higher in the handwritten record than in the computerized record. This goes on for the diastolic pressure, the peak and the trough, and for the heart rate, showing that anesthesiologists, when they do it manually, have a tendency to smooth out the record. The really high peaks won't appear there. The really low dips won't appear there, as they will in the computerized record. And this is how a computerized record could look. It looks very complex, but once you get to know it, the physiological data, and this is from a case, this is from our hospital, this is from a case of cardiopulmonary bypass, cardiac surgery. and you have all the physiological data is input into the system minute by minute, and all the ventilator data, and if you're using any other specific monitors. But the anesthesiologist does still put in the medications that he inserted, the lines, etc. And this, of course, allows you much better to get the information later, say when the patient is in the intensive care unit, and also to query this if you want more specific information. One additional advantage is that you have what we call a unified flow sheet. This is when the patient moves to the ICU. So on a single flow sheet, you can see the operating room, and then you can see the process in the intensive care unit. The fact that when you use a computerized system, you have so much information, you can look at it differently. This is actually the exact same patient with the exact same data, but here, this is the way the clinicians, the nurses and physicians in the intensive care unit will be looking at this data, as opposed to the previous slide, which was the way the anesthesiologist will be looking at it. But part of the issues when you talk about quality is actually when you need to combine information. All the information that we have in the intensive care unit is so complex that it's very, very difficult to combine all of it. And when you have a computerized system, you can put on a single page a setting which will give you, each column here is actually 12 hours. So you have here about 5 or 6 days worth of data. And when you put on this one graph the white blood cell count, the temperature count, the antibiotics that the patient is getting, and the central lines that the patient has, it's much more convenient to appreciate whether the patient, for instance, is developing line-related sepsis, which you can see by seeing that the fact that the white blood cell count is coming up a little bit, and here somebody felt that the line was here already 10 days, so the line was switched, and then the white blood cell count started coming down. And, we used to do this on paper, flipping through a large number of pieces of paper, but this makes it much more convenient. And again, this is another example, just going backwards of the same type of information. You can get a lot of information from various monitors. In this case, from measuring continuous cardiac output and systemic vascular resistance, and looking at complex hemodynamic data. And again, this will allow you to query this and know the exact time that a patient went into atrial fibrillation, or at the exact time that arrhythmia was treated and that resolved. This is going to be more or less like Greek, even to the Greeks here, because it's in Hebrew. But the point is that it's very easy with a computerized record to formulate checklists, any type of checklist that you would like. And what we did in our institution is we actually took the various bundles, the central line bundle, the ventilator associated, the VAP bundle, and put them into kind of a two-page checklist, which the nurses fill every day. And so it's much easier to assess the compliance with the bundles. And you can create sets of medications. For instance, you can create these various buttons, and each button will can be even for a specific surgeon. I work in a primarily surgical ICU, so we have our various surgeons, and each surgeon can have his own specific drug orders, which will significantly reduce, in our hands, the incidence of poorly written drug medication orders. And a big advantage of a computerized system is the fact that you can utilize it for alerts. So this is a type of alert. In this case, this is an alert for a nurse, which tells her you haven't entered the patient's risk of a fall, which she is supposed to do for any new patient in the ICU. So this will come up, and the color has to do with the severity of the alert, and the nurse has to approve it and comment what she did and why she did, and whether why she hadn't done it yet. And we have found that these types of alerts can modify behavior. Dr. Barash mentioned the publication in Anesthesia and Analgesia from the group in Haifa, who showed that if you have an alert like this at the end during cardiac surgery, which tells the anesthesiologist you forgot to turn on the alarms when you go off bypass and start ventilation again, that showed that in their study, they showed a reduction to 0 of forgetting to turn on the alarms. We had a kind of event which talks about check the blood sugar level. If the nurse didn't report within 3 hours a blood sugar level, or she had changed the insulin dosage and did not report a measured blood sugar level, she would get an alert like this. And actually, I'll come back to that in a second, we showed that this can modify the behavior of the staff. We implemented this alert, and we didn't say anything to the staff to begin with. There was no training involved. And I want to show you the level, the glucose level in the ICU, which was at baseline. This is what we regarded as optimal glucose measurements, which was at that time between 80 and 120, just prior to Vandenberg's, or after Vandenberg's study. So we looked at our data from before that, and then we implemented the Vandenberg study. At that point in time, we just told the nurses we would like all the blood sugar levels to be lower. And then we implemented the alert using the computerized system with what they call the event manager, and look at the proportion of adequate blood glucose measurements. It went up when we implemented the blood glucose, the strategy of tight glucose control, and it went significantly higher when we implemented the event. We also had a reduction in the abnormal or poor glucose measurements with greater than 160. It came down when we implemented the tight glucose control, and it went even significantly lower when we implemented the event. And this was not at the cost of increasing hypoglycemia, which is always been the concern. Our ratio of hypoglycemia actually did not, it went down when we initially started the tight glucose control, but when we applied the event manager, it wasn't really statistically significant with regards to our baseline measurement. So we showed in this study that we are able to modify the behavior of the staff just by virtue of putting on this alert. Another alert, which is pretty similar, had to do with hypokalemia, and I'll go back to that for a second. We just showed that when you implement an event which tells the nurse a level of low potassium level has arrived from the lab, then the time to correcting this was decreased. This is the time, the mean and the median of the time to correcting potassium levels for a low potassium before the implementation and after the implementation of that event. And the last thing I'd like to mention has to do with drug administration. Drug administration is a big issue, is a big problem. This is from the ASA Closed Claims Project, 205 drug errors, and we see that there are various types of drug errors of omission, substitution, insertion. Many anesthesiologists have had the experience of swapping syringes and giving a patient the wrong medication because of that. And in fact,
can you turn it back to see the first slide, please?
This
yes.
one?
This one, yes, thank you.
Okay. So there are various types of mistakes, and in each bar you have different levels. That is, the dark blue are cases that led to death, major morbidity, or no or minor morbidity, and in the various types of mistakes.
Thank you.
And here we have the various drugs that were involved. Succinylcholine is a significant component. Some problems with inhalational agents, but also opioids and others. And there were particularly dangerous drugs errors involved with epinephrine. They had 11 deaths of 17 epinephrine-related cases. 6 of them had to do with ampule swaps, and I don't know how the ampules, what they look like here, but in my country they are small 1 milliliter ampules, which are in a dark brown.
Same here.
Dark brown ampule, and they're not, and they're usually close to the atropine, and they're not very, very difficult for someone to accidentally take one out, return it there, and do it, and have a mistake regarding that. So again, syringe swaps, did not read label. This was from asking anesthesiologists what the reasons that led them to anonymously, what led them to make a mistake. And various studies have shown that error rates can be, they're not very, very high, but they are still quite significant, particularly since quite a few of them lead to harm. And the way to control that is probably, or to treat that, it probably has to do with electronics. We implemented in our ICU a barcode reader, not of this type, a somewhat different type, for blood administration at the bedside. The ICU nurses use barcode reading to approve the blood unit, but more and more places are going towards using barcode reading of the patient's identifiers to approve the medication. And in the ICU, this is in the operating room, this is a very, very interesting tool which is coming out, a company called Codonix, in which you, the anesthesiologist, as he prepares the medications for the case, actually prepares the label, and the label has all the information on it, and then this can be read by a barcode reader as part of the computerized anesthetic record, and improve and reduce. It will give you also a sound indication of what the medication is that you're using to try to improve and reduce the chances for mistakes. And this is another system which was published in Anesthesia and Analgesia, which also has to do with specific per syringe barcodes, which can probably reduce mistakes and complications. So, and this last slide probably pertains to Dr. Ramsey's talk previously with regards to cost. Unfortunately, we don't have money to cover anesthesia, so we'll give you the low budget type of anesthetic to put you out. But that's what I had to say, and I thank you for your attention.